everyone. I hope I'm audible and visible. Can you all give me a quick thumbs up if my audio video is fine? Everybody, just give me a quick thumbs up if my audio video is fine. We have a new session of image-based dermatology today. So I hope everybody will be enjoying this session which I will be taking just now on the image-based dermatology. Now before we start, let me introduce myself. I'm Dr. Chesta, your NEET PG educator on the best online platform, Unacademy. Now on Unacademy, we have a free scholarship test in this month scheduled for 23rd of January 11 a.m. I request all my dear students to please use my code, that is Chesta10, to get yourself enrolled. Now all the top students, top 50 students will get Amazon vouchers worth rupees, depending upon their rank, they'll get the Amazon vouchers, and the top students will get Unacademy scholarship for free. Now we have a lot of offers which are going on right now, so you can use any of them using the same code. These are some of our learners who have cleared their recent NEET PG entrance examination and FMG exam. I congratulate each and every one of them. We have a free test calendar for the month of January. I request all of you to please use my code here, and the code is Chesta10 to get yourself enrolled on these classes. We have two types of subscription. One is Plus, which give you an access to Unacademy live classes from the top educators, and we have Iconic subscription, which give you an access to both Unacademy and Prep Ladder together. We have special classes every day at 3 p.m. I conduct free live sessions on Unacademy platform. I request all of you to please download Unacademy and watch my free live class at 3 p.m. every day. We have a highly updated question bank of 25,000 plus questions with detailed explanation. We have a feature which is known as raise a hand feature. We have a lot of new batches which are about to start, and these are the Focus FMG batch for the FMG students. This is a 5-month batch. I request all of you to please be a part of it. And we have a Target NEET PG MCQ discussion batch where I will be taking the dermatology classes. This will start on 31st of this month, that is 31st of January. You have 6 sessions, 6 hours on the same day, and followed by 1st, 2nd and 3rd of the next month. Now I request each and every one of you to please use my code Chesta10 to get yourself enrolled into this amazing platform of Unacademy. The 2-month subscription is a high demand subscription which is going on right now. So it is rupees 6750. This 2-month access to Unacademy platform will give you an access to all the past courses, all the present courses from any of the educator, those who teach on this platform. So requesting all of you to please be a part of Unacademy using the referral code Chesta10. Now let's begin with the MCQ based session. We have top images which I request all of you to look at and tell me the answer. Patient suffering from ulcerative colitis presents with an ulcer on the anterior leg as shown in the image. What can be your diagnosis? Patient with ulcerative colitis presents to you. What can be the diagnosis? Anybody can tell me the answer here. Pyoderma gangrenosum, ulcerative colitis, venous ulcer, tubercular ulcer. Which of the following is the correct answer here? I request all of you to please try answering it on the chat section. Few important points with respect to this ulcer is, if you look at this ulcer, there is a very characteristic violaceous margin. This is very important. So one point which you can see is a violaceous margin ulcer. And can you see this lesion which heals with a very classical cribriform scar? So these 2 points make us little cribriform scar with a very classical violaceous margin. You have characteristic violaceous margin. Characteristic violaceous margin. Background of ulcerative colitis. All these features points towards a neutrophilic dermatosis which is known as Pyoderma gangrenosum. Very, very important. They all points towards a very important differential diagnosis of Pyoderma gangrenosum. Now in Pyoderma gangrenosum, as it is an ulcer, we do not need any antibiotic therapy or any sterile condition. For taking care of these neutrophilic ulcers, we need to give steroids with or without Dapsone. There is no need of giving any antibiotic. It responds very well to the steroid therapy and it causes healing. So very characteristic feature, healing with cribriform scar, violaceous margin in a background of ulcerative colitis. Next image is on your computer screen. Identify the condition shown in the image. Condyloma, this is the second image, very interesting. Condyloma acuminata, Bowen's disease, condyloma lata or hemorrhoides. Marzina, for accessing the free test, you just have to click on, just go to Unacademy Learning app, select the NEET PG Combat. You have to enroll it. So just click on enroll and they will ask you for a code. So you can put this code Chesta 10. Just put this code and then you can easily get an access to that test. Absolutely free. You don't have to pay anything for that. Clear, Marzina? Okay. Now, how venous ulcer looks like? Okay, goes Azam, please remember, first of all, venous ulcer have a very characteristic site. I hope you know that it is present somewhere around the knuckle. So the characteristic site of the venous ulcer. Second is you will see associated venous incompetency. Nothing like that is given in this particular question. No venous incompetency, no venous varicose veins, and the characteristic site is also not seen, and that is why we are ruling out the diagnosis of venous ulcer. I hope this is clear to all of you. Now here, if you look at the lesion, what is that point which differentiate this lesion from the other? Please look at this. You can see there are multiple small projections or cauliflower like appearance. It is not smooth, it is rough, like multiple papillas growing like this. So this rough surface is very important. Rough surface is very important for making a diagnosis of condyloma acuminata, which is nothing but HPV infection. It is genital wart which occurs secondary to human papilloma virus type 6 and 11. In condyloma lata, you will see flat lesion which is moist. Flat lesion which is moist, and it is seen in the patients of secondary syphilis. How does hemorrhoid look like? Hemorrhoids are pedunculated, discrete structure which bleeds on touch or on putting a little pressure. While Bowen's disease is again hyperpigmented, flat top lesion which is nothing but a in situ squamous cell carcinoma. So all these features can be easily differentiated by the correctus morphology, and that is the rough surface of the margin. Is this clear, all of you? Can you all give me a quick thumbs up? Mukif, Gauss, then we have Borkar, Madhurya, Sriramya. I hope this question is clear. Moving to the next question. Cutaneous horn, as shown in the image, is associated with which of the following skin cancer? I can zoom this image so that you can have a look. So this is the face of a patient, and just below the eye there is a hyperkeratotic growth like a horn. It is a cutaneous horn. So you have to tell me that there is increased risk of conversion into what kind of malignancy? Squamous cell carcinoma, then melanoma, basal cell carcinoma, or actinic keratosis. Which is the correct answer? Anybody can tell me the answer? Madhurya, Sriramya. Very well done, all of you. Very nice, amazing. So cutaneous horn, which of the following is the correct answer? Now cutaneous horn, it is a pre-malignant condition. If it is not taken care at a proper time, it can convert into squamous cell carcinoma. And that is why whenever we get a patient of cutaneous horn, we have to send the excised tissue for biopsy. If it has converted into squamous cell carcinoma, you may need to remove even the surrounding normal skin in a probability of squamous cell carcinoma. Moving to the next question, very important question. Identify the condition shown in the image. You can see an elderly woman with flat hyperpigmented lesion. Look at the lesion. It is flat, neither raised, neither depressed. You can see that you have irregular borders. The borders are not smooth. You can see that at few places it is darkly pigmented, at few places it is lightly pigmented, and at few places even you can see hypopigmentation. So variegation in the color, rough border, these are the 2 points which is very classical in this particular question. And can you tell me where do you see this? I'm writing the important point: variegate color or variable color, then irregular border, sudden increase in the size, sudden change in all these features, asymmetry of the lesion. You can even see that it is asymmetrical. It is not a uniform lesion. It is an asymmetrical lesion. All these features points towards a diagnosis of malignant melanoma. And please remember, malignant melanoma, what type of malignant melanoma? It is lentigo maligna. It is the lentigo maligna type of malignant melanoma. Clear all of you? Which is more common on the exposed part in an elderly. Lentigo maligna type. It is very commonly seen in elderly and on the exposed part. Can anybody tell me what is the another name for lentigo maligna? Anybody here can tell me the alternate name of lentigo maligna? Goose Azam, Mukef, Marutya. Anybody can tell me the another name? So the other name for lentigo maligna is Hutchinson triad, Hutchinson's freckle. Okay, so it is the Hutchinson's freckle, another name for lentigo maligna, which is a variant of malignant melanoma. Next question here, please look at this very interesting image. You can see that there are multiple papules which are present on the forehead. Few papules have some black crust at the center, a black deposit at the center. This is how a open comedone look like. I hope you know what are the comedones. We have two types, open and closed. This is a very classical open comedone, which is popularly known as black hat. And why you see the black colored tip? Because the sebum which is present, it get oxidized from the external environment, giving a black appearance. So you have to tell me the correct answer. What is the correct answer here? How will you treat a patient of acne comedone? Topical steroids, topical antibiotic, benzoyl peroxide, or topical retinoid? Anybody here can tell me the correct answer? Anyone? How will you treat a patient with acne comedone? Frequently asked question, FMG, NEET PG, INI-CT. They will ask you this question multiple times. Anybody can tell me the answer? Very nice, Shri Ramya, Goose Azam. The correct answer of this question is topical retinoid. Now, why we give topical retinoid for acne comedones? Because the main problem in acne comedone, development of acne comedone, is obstruction to the follicular outflow. So I hope you know that this is how we have our normal skin. We have hair which is present like this, and this hair is actually present in a cup shaped invagination which is known as hair follicle. Now in this hair follicle there is also one more structure which opens, and that is the sebaceous gland. The material which comes out of the sebaceous gland, it enters the follicle, and through the follicle it comes out on the surface of the skin. When there is obstruction of this part, the material will not start to come out, or will start accumulating inside, giving rise to formation of comedone. So you need to give a keratolytic agent, which can remove keratolytic agent which remove that plug which is obstructing the follicular outflow. Very nice. Let's answer the next question. Please remember, SCC horn is nothing. See, there is no term like SCC horn. We have one terminology which is cutaneous horn. Okay. Now, what is cutaneous horn? When there is exaggerated proliferation of the skin. Why it is important? Because it can convert into malignancy subsequently. So you have to remove it. Okay. There is nothing like SCC horn or SCC horn. Those horns can be converted into squamous cell carcinoma if it is not taken care of. Understood? Azam, I hope that is clear. A child presents with following skin lesion on the chin, what will be the diagnosis? Bullous pemphigoid, non-bullous impetigo, pemphigus, or erythema multiforme, Child with the following skin lesions, what would be the diagnosis? Bullous pemphigoid, non-bullous impetigo, pemphigus, or erythema multiforme. Anyone? Very nice, Vimal. Amazing. Pathan, Goose Azam. Very nice. Anybody wants to answer this? Yes. Now if you look at the image, it is a very classical yellowish colored or honey colored crust, and I hope you all know that honey colored crust is very specific for non-bullous impetigo, which is mainly because of streptococcus, more common than staphylococcus. Can you tell me what type of crust you get in bullous impetigo? Do you get any crust in bullous impetigo? Yes, we get what is called as a varnish crust. It is not yellow colored. The varnish crust is little transparent sort of crust which is not seen in non-bullous. So here you can see it is honey colored or yellow colored, and that is why option number 2 becomes the correct answer. Next question. A patient with blisters on the skin, Tzanck smear shows cell as shown below. Which of the following statement is true? Which of the following statement is true? Seen in herpes, hypochromatic nucleus, perinuclear halo, or it is due to keratin mutation. Anyone can tell me the correct answer of this question? Anybody can tell me the correct answer? Seen in herpes, hypochromatic nucleus, perinuclear halo, or due to keratin mutation. Anyone? So if I zoom this image, it becomes a little clear. There is a single cell, very large single cell with multiple nucleus inside them. I hope you can appreciate this different nucleus. So this is how a multinucleated giant cell look like. Multinucleated giant cell look like. ठीक है जी? So this is a multinucleated giant cell. Now multinucleated giant cell occurs whenever you have secondary acantholysis or you have keratinocyte damage, and it is very specific to viral infection, that is herpes. Next question. Again I am showing you the image. Look at this image. There is a plaque, and on this plaque, over this plaque, there is a scale which has a very characteristic. Please look at this. There is a scale which is fixed from one end and open at another end. Tell me the correct answer. Tell me the correct answer here. Patient present with the lesion as shown. What is or which is the correct answer? Powdery, silvery, mica-like, or cola red. Powdery, silvery, mica-like, or cola red. Powdery, silvery, mica-like, or cola red. Anyone? Shiramya, Mukef, Azam, Naveen. Very nice. This is how a cola red scale. What do you mean by cola red? Cola red means collar-like. Now if anybody is wearing a collar right now or a shirt with a collar, you must be knowing that one end of the collar is free. One end of the collar is free. Okay? So, and it is attached to the shirt from another end. Similar to that, the scales of the collar-red scales, they are attached to the plaque from one end and another end is open. And that is why they are known as collar-like scales, which is very classical of Pityriasis rosea. Okay? Collar-like scales, classical of Pityriasis rosea. Now again, this is a very interesting image. I request you to have a look on that. I am zooming the image for you. So here we have a patient who presented with the lesion as shown. The best way to describe the lesion would be a dermatomal, Blaschkoid, linear, or segmental. How will you classify this lesion? If you want, I can just zoom this image for you. So just have a look. It has a very classical pattern on the trunk. Combat, Marzina, Kaustubh, Goose. Then we have Madhurya, Naveen. Can you tell me what is this a specific pattern of? Very nice, Kaustubh. The correct answer is Blaschkoid, or this is the embryonic pattern, also known as embryonic pattern. These are nothing but embryonic migration lines or embryonic lines. If the patient has any defect during the embryogenesis, they will present in a migrational line known as Blaschkoid lines. So very nice, Vimal, very nice, Mukif, Blaschkoid pattern. Now layer of the skin with maximum desmosome interconnection. The purpose of giving you this question is to tell you how does a normal skin look like. It's a very easy question, but I want all my students to know how does the normal histopath look like. Now, can you see this basket weave appearance on the top? This is stratum corneum. Now just compare this above layer, the top layer from the other layer. There is no blue dot which is seen here. Can you see any blue dot in between? No. So stratum corneum is a anucleated layer which is present in a basket weave pattern, Now just beneath these, I hope you can concentrate at this layer, 2 to 3 cell layer thick. Can you see this? And if you notice, there are some granules which can be seen inside the cytoplasm. This is how a stratum granulosum look like. Stratum granulosum is usually 2 to 3 layer thick, while stratum corneum is 4 to 5 layer thick. Now beneath this, can you see this large polygonal cell layer, the whole thickness? This is stratum spinosum. And in the end, can you just look at these cells which are present in perpendicular orientation with some brownish color in between? This is stratum basale with the melanin. I hope you know that melanocytes are present in stratum basale. So presence of melanin is observed more frequent in the lowermost layer. So A is stratum corneum, B is stratum spinosum, C is stratum basale, and D is actually dermis. At the dermoepidermal junction, D is actually dermis. Okay? I hope this is clear. Now, because stratum spinosum is the thickest cell layer, and that is why the desmosomal interconnections are maximum in this layer, because it is thickest layer. Can you all give me a quick thumbs up if you understood how does a normal histopath of the skin look like? Can you all give me a quick thumbs up if you can easily differentiate a normal from an abnormal? Now let me give you a skin which is not normal. So I will show you now an image which is of a diseased skin. Okay, so this is an image which we have with us. Just a second. Now please compare that image with this image. Just compare the previous image with the current image. Do you see any change in the stratum corneum? Yes or no? Do you see any change? What is the change? In the normal skin, the stratum corneum was very thin or very loosely present like this, like a basket weave pattern. But here you can see that the stratum corneum has so many layers which are very compactly packed. This is a very classical feature of hyperkeratosis, where you have compact arrangement of stratum corneum. What is the next feature? Can you see the blue dots here, which is not normally seen? This is a blue dot which corresponds to the retention of the nucleus, known as parakeratosis. So you have hyperkeratosis and parakeratosis. When you just look at the image below or the line below, there is no stratum granulosum. So there is agranulosis, and you can see that just above the dermal papilla, the epidermis is thinned out. So suprapapillary thinning. All these features are very, very classical of psoriasis. What have we learned? Hyperkeratosis plus parakeratosis. Hyperkeratosis plus parakeratosis means thickening of the stratum corneum, and second is presence of nucleus. Second is agranulosis or hypogranulosis, decrease in the thickness of stratum granulosum, and because of enlargement of these dermal papilla, there is suprapapillary thinning. I hope you have understood both the images now, and the only purpose of telling you this question is to compare how does a normal skin look like with respect to the defective skin. Can you all very quickly give me a thumbs up if you have understood? Again requesting, if you like the way I teach dermatology, please use my code. The code is CHESTA10, CHESTA 10, and take a short subscription of Unacademy, that is 2-month subscription, which is around 6700 rupees. It is worth attending. All the educators will be teaching their subject very, very interestingly and short. They will help you understand the topic very well. ठीक है जी, चलो. So I think this question is clear, and we have also discussed another question. with psoriasis. Coming to the next image, please tell me the correct answer of this question. Please tell me the correct answer of this question. There's an image and the question is, a patient have 7 irregular hyperpigmented macules on the trunk, multiple small hyperpigmented macules on the axilla, groin, and since early childhood there were no other skin lesions. What is the most likely investigation to support the diagnosis? What is the most likely investigation to support the diagnosis? Slit lamp examination, measurement of intraocular tension, examination of fundus, and retinal artery angiography. Think about the diagnosis. Look at the image. I hope you have understood the diagnosis. Vimal, Naveen, Sriramya, Mukesh, Dr. Kostu, very well done, all of you, very nice. Can you tell me what is the diagnosis, Dr. Kostu? Or anybody else want to tell me the answer? What is the diagnosis here? Yes, amazing. Please remember, diagnosis here is Neurofibromatosis 1, NF1. And the image shows what? This is cafe au lait macule. Now if you remember the diagnostic criteria, you should have more than equals to 6 cafe au lait macule. I hope you remember that. More than equals to 6 cafe au lait macule should be there, and here it is 7. So it is one of the criteria. Multiple hyperpigmented patches in the axilla. This is axillary freckling. Now other features which you need to know in these individuals are presence of iris leaf nodule, and to look for that you need to do a slit lamp examination. Okay, so you will look for iris leaf nodules. Okay, and can you tell me how many iris leaf nodules should be present for keeping it under the diagnostic criteria? Anyone? How many iris leaf nodules? It should be more than equals to 2. How many neurofibromas should be there? How many neurofibromas should be there? It is also more than equals to 2. And cafe au lait macule should be more than equals to 6. It should be more than 15 mm if it is a post-pubertal individual, and it should be more than 5 mm if it is the pre-pubertal individual. So many things I have discussed with this particular question. I hope you have enjoyed this. Okay, can you all give me a quick thumbs up if you have understood? Again requesting, these are some of the very important topic. I will be conducting a MCQ based revision for the NEET PG. It will start on 31st of this month, 31st January. I request each and every one of you to please get your subscription today. You know how to take it. We have a code, my name CHESTA 10. Another image based question. So I hope the image is very clear to all of you, and if you want I can zoom this also for you. Look at this image. What can you see? You can see that there is a child with dark large sized scale. You have a black colored or a dark colored large sized scale. In addition to it, we have other features like cryptorchidism, we have hypergranulosis, and we have steroid sulfatase deficiency. So even by looking the question or by looking at the image, you can tell me the answer. Very nice, Kaustubh, Madhurya, Marzina. Anybody else want to add? Amazing, all of you. Very well done, all my dear students. I can see a lot of you with the correct answer. So what is the probable diagnosis? It is an X-linked recessive ichthyosis. Please remember, the only difference between X-linked recessive and Ichthyosis vulgaris clinically is, in Ichthyosis vulgaris you will see yellow color small fine scales which is present all over the body except for the flexures. But in X-linked recessive you will see large dark color which is mainly black or brown scales present all over the body without any sparing of the flexures. So that is how you can differentiate both Ichthyosis vulgaris, which is autosomal dominant, from X-linked ichthyosis. Other differences are, when you do a histopath, you will see agranulosis in Ichthyosis vulgaris, while you see hypergranulosis in X-linked ichthyosis. There is deficiency of filaggrin in Ichthyosis vulgaris, but there is deficiency of steroid sulfatase in the patients of X-linked ichthyosis. And with respect to association, you have cryptorchidism and you have corneal opacity. Both these associations are seen with X-linked ichthyosis. Can anybody tell me what is the association with Ichthyosis vulgaris. What is the association of Ichthyosis vulgaris? It is associated with that of atopic dermatitis. Atopic dermatitis. Clear, all of you? Can you all give me a quick thumbs up if this point is clear? Amazing, everyone. Let's answer the next question. We have an image. Look at the image first. So this is the axilla. I am showing you a axilla. Tell me what is the answer. The axilla of a patient shows multiple small hyperpigmented macules. So what is this? Derrier sign, Crowe sign, Hutchison sign, or Auspit sign? Very nice, Dr. Kostu. Very nice, Marzina, Goose, Mukef. Very well done, all of you. So this is an axilla which shows multiple hyperpigmented macules, and this has to be a Crowe sign, and this is also known as axillary freckling. And please remember, this is considered to be a pathognomic lesion. Pathognomonic lesion of neurofibromatosis type 1. Cafe au lait macule is not a pathognomic lesion. It is the Crowe sign or axillary freckling which is considered to be the pathognomic lesion of neurofibromatosis. Now another question we have here. So I think we need to just have a look on the image. Look at the child. There is presence of periorificial lesions. Okay? There is periorificial lesions which have started on 6 months when we wean the baby. There is also associated diarrhea. Which of the following will be considered as the best possible answer? You can have multiple answers here, but which is considered to be a best possible answer? Weaning, then we have associated diarrhea, and we have periorificial dermatitis. Very nice, Sri Ramya, Kaustubh, Mukef. The correct answer is Acrodermatitis enteropathica, which is a congenital zinc deficiency. How will it present? It presents with a classical triad of D, A, D. And what is this triad? You have diarrhea, you have alopecia. What else? You have diarrhea, you have alopecia, and you have dermatitis. Diarrhea, alopecia, and dermatitis, which is periorificial. Clear, all of you? With this, we are done with the today's session. I hope you have enjoyed the whole session. Requesting all of you to please subscribe Unacademy using my code CHESTA10. This code will give you additional 10% discount. Also subscribe the free YouTube channel. The name is Let's Crack NEET PG. So the one which you are on right now, please subscribe it. We also have a Telegram group, so you can join the Telegram group with the same name, that is Let's Crack NEET PG, for any doubt clearance or any link of the classes. Please don't forget to give a thumbs up to this video. Please give thumbs up, and don't forget to press the bell icon for all the notification. Again, I am reminding you for the NEET PG Combat, which is scheduled for January 23, 11. Use my code CHESTA10 to get yourself enrolled on this amazing platform. Thank you and take care, all my dear students.